decide what it is that we're going to do? How do we decide what we're going to do with the patient, how we're going to implement that, and probably the most important thing is how we're going to decide for which patients is this approach the most appropriate one to take. And this is where the idea of pain neuroscience comes in, because I don't think this is the best treatment for everybody. I think it is very effective for specific patient groups who form a large proportion of the people with lumbar spine and pelvic pain. But I also think there are other interventions that are appropriate for specific groups of patients as well. And we need to be able to decide who should we prioritize for this type of intervention. And pain neuroscience gives us some idea about how we might go about making that decision. So I would like to talk about some of those issues today. So what I'd like to do to start with is give you some context of where I think motor control exercise fits into the whole spectrum. And then we're going to deal with 5 separate topics over the next couple of hours, and I'll give you a bit of introduction to what I think those what they will be. So we all understand that low back pain and pelvic pain is multifactorial, that there are biological components, psychological components, and social components. And motor control intervention is about addressing primarily the biology of targeting the way that a person controls their lumbar spine and pelvis. And our assumption is that people with low back pain, many of them have poor control of their spine, and our intervention strategies aim at trying to improve the control of their spine to reduce their symptoms and improve their function. But we always need to recognize that in a patient in front of us, there are also going to be factors associated with psychology. There are going to be social factors that are all going to interplay. So motor control is one of the aspects, and for some patients, it is the major aspect, and I think that's where motor control fits in. Now, if we look in the literature, it's been agreed for many years that exercise really is one of the most effective treatments for low back pain. There is no treatment more effective than exercise. It's included in clinical practice guidelines internationally, but there's very little guidance about what type of exercise should be used. And there's many different things that we target with exercise, such as strength, endurance, flexibility, and motor control is one of these aspects. So amongst all of the different exercise approaches that have been studied in back pain, one of the most researched is motor control training. And really my purpose for today is to answer these 2 questions, and that is, well, what is it? And who does it work for? So who is it that we're going to be effective in treating in this way? So what I'd like to do over the next few hours is address 5 things. And the first thing is, I want to talk about what I think is optimal control of the lumbar spine and pelvis. So if I'm going to suggest that people with back pain have poor control, you first of all need to understand, well, what do I think is ideal? What is the optimal strategy that people use to control their spine, so that we can then understand, well, how might that be compromised in a person with back pain? So the next thing is to then, of course, consider, well, what does go wrong when people have back pain? The next thing is to consider this issue that I highlighted at the start, and that is, can understanding the pain neurobiology that is explaining an individual patient's pain help us make a clinical decision? So can we identify features of the person's pain presentation that tell us that, okay, a motor control intervention is what I would like to prioritize because I believe it's going to be most effective for this individual patient? The next thing is to consider, well, how can we then apply that in practice? So how can we put all of these ideas together into a clinical approach? And what I'd like to do is to take you through an overview of the way that we go about designing an intervention. So what are the aspects we will assess? I'm going to show you some videos. I'm going to go through some clinical observations, some clinical pearls, give you some ideas about what it is that we might assess across several different features of people's motor control. And then I'm going to talk about how we might then use that information to design a treatment program for an individual patient. And one key aspect of that is I'd like to talk about designing the intervention from day one, when we first assess a patient, right through to when they're back at function. So I want to talk about the spectrum and how we progress exercise through that. And then finally, I'd like to talk about the evidence. So what evidence do we have that if we assess and then train people in this way, if we target it to these individuals, can we actually be effective? Is there evidence for that? So the first thing I'd like to consider is, what is optimal lumbopelvic control? It's really complicated. There are many things to consider, but what I'd like to do is to talk about 5 principles that I think are critical, that help us understand the overall nature of ideal control. So 5 key principles of optimal lumbopelvic control. So what I'm showing you here is 2 videos of men attempting to run. So if you look at the fellow on the left, he's keeping his spine upright. He's using a strategy that involves very much keeping his spine stiff and rigid. So keeping his spine in a single orientation. And you might think, well, that's good control. He's really not moving his lumbar spine or pelvis. He's keeping it controlled. But there's something missing. And if you look at the fellow on the right, what you can see is that he's also successful in keeping his spine upright, but he's also moving. He's getting some movement of his lumbar spine with each step that's acting like a shock absorber. He's getting counter rotation between his pelvis and his shoulders, which allow for some load transfer through his body. He's got movement that's assisting the function, because by rotating his pelvis and spine, he's able to extend his legs further to complete the task of running. And he's also sharing the load around many different regions of his body. So rather than all of the forces being absorbed in one particular region, he's actually sharing that load around. So what you can see is that these are 2 extremes of spine control. And what I'd like to suggest that ideal control is a balance between movement and stiffness. Now, for many years, exercise interventions that aim to deal with motor control or spine stability were primarily aiming to stop people from moving their spine, getting them to brace and co-contract their trunk muscles so that their spine didn't move, so that their pelvis didn't move when they performed a function. And what I'd like to suggest is that that's too rigid, that we actually need to move as well. So the first thing I'd like you to see from this slide is that there is this spectrum from strategies that involve stiffening to strategies that involve movement. Now, for this task, which is running, it is clear that a dynamic strategy, so this strategy that involves some movement, has some benefits. But other functions, such as lifting up 100 kilograms from the floor or pushing or pulling heavy weights, those functions might instead be better off to use a more rigid strategy. So what we need is the nervous system with the capacity to be able to stiffen the spine when it's necessary for some functions, but move the spine when it's necessary for others. So I think the single most important thing for us to consider in terms of optimal control, and then considering, well, what happens with back pain and what might we like to change in a person with rehabilitation, it's about finding that balance. You can certainly move too little. You can certainly move too much. So in this particular situation, I'd like to suggest that the fellow on the left is not moving enough. He's not using his spine as a shock absorber. You can see he's also got a lower limb injury, and there is some really nice evidence from Jacek Kolovecki that shows that people who don't move their spine are more likely to injure their knee. So there is a reason why This interaction between different segments and keeping the spine moving is beneficial. But there's certainly evidence that moving too much is also a problem. So it is about a balance. The second principle is that we need to consider that all muscles are important. There has been a lot of emphasis placed on the deeper muscles of the trunk, and a lot of that emphasis has been based on some of the early research that I was involved in. So studies that showed that muscles like the transversus abdominis and the multifidi and the diaphragm and pelvic floor, which I'll talk a bit about a little more later, there's evidence to show that those muscles are important. But I think we need to remember that all muscles contribute in some way to spine control, but the function they perform is different. So all of the muscles around the lumbar spine and pelvis are going to be relevant for control of the spine. How might we conceptualize the different contributions? So if we think about the spine like an unstable stack of blocks, perhaps our purpose is to be able to keep the spine upright. And if we have muscles that are long, that cross from the thorax down to the pelvis, that act like the ropes of a flagpole, those muscles are going to be able to keep us upright. But they can't control the relationship between individual spine segments. So if we have a system of muscles like the transversus abdominis and the multifidus that attach to each individual vertebra, that tension the thoracolumbar fascia, that can control intersegmental motion, their function can be focused on controlling intervertebral motion, while the more superficial muscles keep us upright and generate forces. So the message is that for ideal control, we need the whole spectrum of muscles, from the small intersegmental ones to the long torque producing ones. The deeper ones critical for intervertebral control, the larger ones critical for movement and for stiffness of the spine. So it's clear that we need all muscles. Often when people get back pain, these deeper muscles do too little. Sometimes in people with back pain, they develop asymmetries or they have overactivity of some of these larger superficial muscles. So the spine becomes too stiff, or they become asymmetrical and they can't control in particular directions. So it's really critical to consider all muscles are important, and our assessment and rehabilitation is going to need to consider the whole spectrum of muscles. The third principle to consider is that we also need to think a little bit beyond muscle, and that is we need to start thinking about features such as the thoracolumbar fascia and the anterior fascias of the trunk and intra-abdominal pressure. So the fascial structures provide direct attachments for the muscles to the lumbar vertebra. These fascial structures are stiffened by a contraction of muscle. So the transversus abdominis pulls on the posterior and mid layer of thoracolumbar fascia. The paraspinal muscles bulge and stiffen the posterior component. The abdominal muscles tension the anterior part of the fascia. They also increase intra-abdominal pressure. And we've done a large number of studies in many different situations where we've shown that tensioning the fascia and increasing intra-abdominal pressure have an effect on the spine, and I'll talk a little bit more about that in a moment. But what we know is that, again, just like everything, there's a balance. You can have too much stiffness of fascia and too much pressure. You can have little. We've got to get it just right. But the important thing is it's not just about muscle contraction, it's also about controlling pressures and fascial tension. Now, if pressure and also fascial tension is important, we then need to, of course, recognize that the abdominal cavity has a roof and a floor. So there is the diaphragm, which is the roof of the abdominal canister, the pelvic floor, which is the floor of this abdominal canister, and those muscles are necessary to enable the pressure to increase. If there is dysfunction of the pelvic floor or dysfunction of the diaphragm, so a breathing disorder or continence or prolapse issues, then there may be poor control of the spine because they're not able to control the pressures. Now, we've done a lot of work just to confirm that there is an important mechanical contribution of the pressures and fascial tension to lumbar pelvic control. We've done studies in humans where we electrically stimulate the diaphragm to increase intra-abdominal pressure. And what we show, and if you look at the image on the right, what that's showing you is when I place a force on the spine, how much resistance or how much displacement do I get from that force? So if you look at the yellow line, what it says is that in order to get 2 millimeters of displacement, I need to have 60 newtons, so 6 kilograms of force on the back. So pushing on the spine with 6 kilograms, we get 2 millimeters of displacement. If I then increase intra-abdominal pressure through stimulating the diaphragm, I now need 8 kilograms of force on the spine to move the same distance. So what that tells me is that pressure has made it more difficult to get into segmental motion. So pressure does appear to help control intersegmental motion. And that's some work we did a long time ago. We've also done some animal experiments that do the same thing, where we look at intersegmental motion. So how much movement do you get between individual vertebrae with and without pressure? And what we show is that if you contract the diaphragm or you contract transversus abdominis, you get a reduction of intervertebral motion. And we've also shown that if you cut the thoracolumbar fascia, those effects disappear. So what that tells me is that both fascia and pressure are important. The fourth key principle of optimal lumbar-pelvic control involves the neural control strategies. And there are many different regions of the nervous system involved in the control of movement. In fact, the majority of your cortex and many deep brain structures and spinal structures devoted to the control of movement. So there's many different mechanisms that your nervous system uses to control the spine in different functions. And what I'd like to do is really talk about some key understandings. And the first is that there really is 3 basic ways in which the nervous system controls the spine. It needs to be predictive. So if I'm going to take a step, what that does is it challenges my spine. And because my brain is controlling that step, it knows that it's going to happen, so it can predict. If you're catching a ball, you can see when the ball's coming, you know when it's going to arrive in your hands, you can predict. So one way that we control the spine is through predictive feed-forward strategies, so getting ready in advance of a load. But we can't predict everything. Sometimes things happen unexpectedly. So we're standing on a bus, the bus takes off and we get disturbed. We need to be able to react to that. So feedback control, so reactions in response to loading. But reactions take time and we can't predict everything. So one thing that we do in addition to those strategies is to maintain a small amount of tonic activity. So when we're standing, there's always a little bit of activation of the deeper trunk muscles. There's a little bit of activation of quadriceps. There's a bit of activation of soleus. These muscles providing a little bit of intrinsic control. So their activation at a low level, just tonically buzzing away, just enough activation so that if you were to be perturbed or challenged by someone pushing you or the ground or you slipping or whatever, this low level tonic activation is there to get you ready, just to give you that initial level of control. And on top of that, you can add these reactive responses, or you can add to that activation through predictive adjustments. So there's 3 basic strategies, and let me give you sense of that. So here's a person moving their arm. Before you move your arm, you know you're going to do it. You know it's going to challenge your spine, and there's activation of deep muscles that occurs in advance of that. There's also activation of all of the other abdominal muscles as well, just a little later. Here's a reaction. So a person is catching a mass in a bucket, and what we can see is that just after the load hits the bucket, there's a stretch reflex of the biceps to help maintain the position of the arm. And then there's this more involved response of trunk muscles to react and control the spine. So some feedback loops are really simple, just stretch reflexes. Some are really complex and involve your whole body, and they just take a little bit longer. And then here's an example of tonic activation. So the person is walking or running, and what you can see is that their transversus abdominis is tonically buzzing along. It varies a bit. So it's a bit more active when your foot hits the ground, but it's pretty much tonically active throughout the whole gait cycle. So there's always a little bit of activity there, just in case something unexpected was to happen. The same thing applies to the diaphragm. So I mentioned before that your diaphragm has to be active as part of those adjustments in order to help intra-abdominal pressure control the spine. And what we see is that before you move your arm, you've already got activation of the diaphragm to prepare you. If we get people to move repetitively, again, what we see is the diaphragm is now tonically active. So there's a tonic increase in diaphragm activity. On top of that, there's activation to help you breathe, but there's always this ongoing activity to give you that level of control, regardless of what's happening. We've also done pelvic floor muscle studies. So we've done studies looking at pelvic floor recordings in men and women, and those studies show that there is an increase in activation of muscles of the pelvic floor that precedes the movement of the arm. So that's been shown in men and in women. And in males, we've even made recordings of their urethral sphincter muscles, and we've been able to show activation before you take a step when you're walking. So what all this shows is that the pelvic floor muscles are definitely part of this postural adjustment to control the spine. Here's repetitive movement of the arm for men and women. So a person moving repetitively, and again, we see the tonic activation occurring in these pelvic floor muscles. So they really are part of these postural adjustments. And here's a recording of pelvic floor muscles. And you can see there's tonic activation to begin with. And then when the loading occurs, and you can see this reflex response in the biceps, soon after that, you see an increase in the activation of the pelvic floor. You can't see exactly when it begins, but you can certainly see that there is recruitment of the pelvic floor as part of that reactive control. So, as I said, in this fourth principle, there really are three key strategies: predictive, reactive, and tonic activation. And why that's important is because I think we need to be able to train that in people with pain. So we need to be able to evaluate and train their capacity to prepare for a challenge. So control your spine before you push or lift or pull. We need to teach them how to react. So we need to put them in challenging balance situations so that we can train the system to react appropriately to control the spine. And we also need to train low-level tonic activation. A key aspect of that is that you can only maintain tonic activation at a very low percentage of MVC, so around 6%. So I'm not talking about strong tonic activation, I'm talking about very gentle tonic activation. And Jacek Kolovecki showed that less than 5% is sufficient to give you that ongoing level of control that's necessary in case you get unexpectedly challenged. And then the fifth principle is that when we think about training a patient, we do need to train them across the spectrum, which means that we need to teach them how to use co-contraction strategies to prevent their spine from moving when that is necessary for function. So we need to teach them how to statically control the alignment of their spine when they push and pull and lift. And we also need to teach them to be dynamic, to control during movement. So our exercise programs are going to need to include both of those extremes. And we're going to need to give people some education and training about when you might apply one versus the other so that people can match the strategy to the task. So what I've said so far then is that to try and distill what's important about optimal control of the spine, I think there's these 5 key principles that help us understand how your nervous system goes about using the muscles to meet the demands of function. Now, before we go on to the next section, which is to consider the how this might all change in people with back pain. Does anyone have any questions or any comments about what I've said so far about ideal lumbopelvic control? And I'm happy for you to either put those in chat or to speak. In fact, it's probably easiest to speak because I can't find chat. But if anyone does have any questions, do feel free to ask them. I'm very happy to get some discussion going. Oh, there, I can see chat now. No, I can't. There it is.
So for now, there are no questions in the chat section. If there will be any, then I will let you know.
Okay,
Otherwise,
great.
we have opened the forum. Maybe
Okay.
anyone would have asked question.
Sure. But everyone who is online, do feel free to ask questions. I'm more than happy to ask, happy to discuss. Okay, so let's go on then and think about, well, how does this change when people have low back pain? So the way I'd like to discuss this again is, I don't want to go through in enormous detail all of the different aspects of how motor control changes. Again, what I'd really like to focus on in the session today is the principles of how I think what I think the evidence is showing us about how motor control changes. And I think one way to think about this is in terms of different aspects of motor control. So posture, movement, and muscle activation. So we all know that posture has been discussed for many years with relevance to low back pain. And there's been some criticism in the literature about whether motor posture is relevant. And one of the things I think we need to consider is that a lot of work that has considered whether posture is relevant has tried to identify one posture that might be associated with back pain. And the other aspect is that people often look at the healthy population and say, well, people in the healthy world also use these postures, so they mustn't be very bad for you. They can't be related to pain. But I think we need to turn the question around. And the first thing to consider is that I don't think there is one posture that is negative for, that's related to back pain. But I think there is a range of different postures that are going to be relevant for individuals. And there's some really beautiful evidence of that comes from different research groups. So there is evidence to suggest that some people with low back pain sit in a posture that's too flexed, and then they've got creep on an excess load on their spinal structures, and this can be provocative. There are other people who actively hold themselves in an upright position and do that with excessive recruitment of their longer rectus spinae muscles, getting compressive load on their spine. And then there's also people who have more of a sway back posture where they hang into extension. So the center of mass of their trunk is too far back and they hang into extension, taking their spine to the end of range. So each of these different extremes has a relevance for back pain for an individual. And one of our challenges clinically is going to be to look at a person's posture and decide, are there features of the posture for that individual that may be relevant for their symptoms? And one way to tell that is to get them to demonstrate their postures, identify features, and then change it and evaluate the response to improvement of or changing or resolving their postural problems. So this particular person who's got the long rectus spinae activity, that person's going to benefit from strategies that teach them to reduce that overactivation and to regain the control around the thoracolumbar junction. This person down the bottom who has a sway back posture, a lot of their control is going to be about getting them to learn to change the relative position of their thorax and pelvis. These people are not going to have very much muscle activation, so they're going to need muscle training to be able to now adopt a more ideal position for them. And then this person who's slumped, obviously we need to be able to teach them how to control their lumbar lordosis so they're not hanging in the end range of flexion. So I think I think posture is relevant, but we need to identify for the person which are the features that are relevant for that particular individual. And it is true that there are people who have no pain who use these postures. But one thing we need to consider is that it's about a relationship between postures and exposure and individual tolerance. And there might be a person who, when they sit, they use this particular posture, but they may not sit very much, or they may have a body structure which is a little more resilient than another person. Again, there may be people who, when they sit, they do use this posture, but they may only use it infrequently. So to understand the relationship between postures and pain is a bit more complex than simply looking at a community and going, yep, you've got that posture, you have that posture, you're going to get pain, you're not. It's not that straightforward. But the key principle is when we have a patient with back pain, we will evaluate their posture and identify what features might differ from the ideal. And then if we change that, does it have an impact on their symptoms? And that can help us understand. So there are many different presentations of postural change that occur in people with low back pain. What about movement? Well, it's the same. There's a whole range of different ways that people may move that challenges the loading on their tissues. So for example, the person at the top isn't moving the spine at all. So they've got co-contraction of their erector spinae muscles. You can see that they're not allowing their spine to flex at all. This is going to be putting excessive compressive load on the spine and is not going to be ideal. And if that is relevant for the person's symptoms, it may be something you want to change. The next person has a sway back. So when they come up, they thrust their pelvis forwards and hang into that extended position. So for them, it's not about having too much activity. It's about hanging passively into extension and loading their spine. So this person needs to learn to change their movement, not to hang into extension and to improve muscle. This image at the bottom is from Shirley Salmon, and what it shows is that sometimes when people try to rotate their hip, they use their pelvis and spine instead. So rather than that strategy, they use their spine and pelvis. And the idea there is that every time they do a movement that involves their legs, so kicking a ball, running, doing other functions, they're going to put excess load on their lumbopelvic structures. So what we can see is that just like with posture, there's not one movement that is needs to be considered in people with back pain. What we need to consider is that their individual patients will present with different strategies of movement that may or may not be relevant for their symptoms. And our challenge as clinicians is to identify what aspects are potentially problematic, to change them and evaluate whether we can make a difference to their symptoms. What about muscle? Now, we've done lots of work looking at muscle, so over many years, and what we've been looking at is the whole muscle system. Some of our data has identified compromised or reduced activity. So too little activation, activation that's too late. So delayed recruitment of the transversus abdominis, reduced activation of the multifidi, structural changes in muscle. So atrophy, fatty infiltration, and fibrosis of the multifidus, which means that the muscle isn't going to be able to meet its mechanical demands or to be able to control the trunk. So we've done arm movement studies where we look at the whether people can prepare with the appropriate muscles. Healthy individuals activate their transversus abdominis before they move an arm. People with back pain activate it later. But you can see there's lots of variation. There's some people who probably don't have much of a delay, and there's other people who have a large delay. We've looked at multifidi, same thing. So the shorter, deep fibers of multifidus are commonly delayed and compromised in people with back pain. And when we look at people running and walking, we often see that there is phasic rather than tonic activation. So healthy individuals, when we look at the transversus, they activate tonically throughout the gait cycle. when we look at people with back pain, often they only have a burst of recruitment of transverses at specific points in the gait cycle. So they don't have that ongoing level of tonic control. But that's only half the story. We often see also that people use too much activity. So people are often excessively activating their trunk muscles. So too much, too early, too long. So we can have situations of too much co-contraction, and that's a problem, because if you're co-contracting too much, you're then going to get more compressive load on the spine, and that's potentially problematic for an individual. If they're co-contracting too much, then they're not going to move. So that means there's going to be less shock absorption, less of that transfer of forces through the body, and less variation. So a little bit of variation is good to enable the structures to share the load around. So if there's many reasons why having too much muscle activity can be just as problematic as having too little. Often what we see is that people with low back pain have a bit of both. There's some aspects of the muscle activation that is working too little, and there's some aspects of muscle activation that's too much. So for example, there may be a person who is excessively recruiting their long erector spinae with poor recruitment of the multifidi, or they may be excessively bracing their abdominal muscles, external oblique or internal oblique, with poor control of transversus abdominis underneath. So it's often that we find this combination occurring together. So again, our challenge clinically is to be able to work out what are the features that we need to address. Another aspect, of course, is sensation. And that's clear, because if you don't know where your spine is, if you can't perceive how your spine is moving, then you're not going to be able to control the position or the movement. And there's lots of evidence of change. And this applies to all regions of the body. There's evidence of poor proprioceptive function related to the spine, to the pelvis, hips, knees, ankles, shoulders, neck. Just about every region we look at, there's some evidence of poor proprioceptive function. There's also evidence of poor use of proprioceptive input. And what I mean by that is that some studies have shown that even though proprioceptive information may be available to the nervous system can ignore it. And there's some really nice work from Simon Brumain in Belgium that shows that people will often ignore the sensory information from their back. That's really interesting, because what that means is that maybe one of our strategies is to get people to learn to perceive movement, so we can train them to use their sensation again. So it's not because there's damage that means that the sensation isn't available. Maybe we can train people to use the information more appropriately. And there's some evidence also from Hair to Floor in particular that shows a change in the brain's representation of the body. So on the sensory cortex, we have a representation of the body, and there's evidence to suggest that that is distorted in people with back pain. So the brain thinks the body is a slightly different shape when people have pain, and that's going to have an impact on understanding and planning of movement. And then, of course, there's this other issue of coordination of functions. So as I've highlighted earlier, for ideal control, you need to have a diaphragm and a pelvic floor that is functioning appropriately. And we have evidence to show that people with back pain can also present with breathing disorders. People with breathing disorders can present with back pain. Same thing with pelvic floor dysfunctions. So pelvic floor dysfunction is very related to the presence of back pain, and balance disorders as well. So another multiple function of the trunk muscles is your trunk muscles don't only control the spine, but they also help maintain balance. And if you have poor balance, or you could end up with poor control of the spine as a secondary effect. So there's lots of evidence of poor coordination of functions being relevant. And that's really relevant for sports people who might be putting themselves in demanding balance contexts and in demanding breathing situations as well. So what I've tried to do with that is to give you an overview of how I think motor control might change in people with back pain, particularly thinking about the systems of posture, movement, muscle activation, proprioception, and or sensation, and this coordination of functions, because each of those domains is where we might find changes. Does anyone have any questions about what I've said so far related to pain and how movement and motor control changes in pain? Again, if you put something in chat, or if you want to just allow your video and microphone and ask.
Yes, sir, I have a question.
Yeah.
So you said that suboptimal sensory function can be the leading cause of the pain. And I have a question that if it is the leading cause of pain, then how can you differentiate muscle guarding? Because I think that sensory function, when it is, it's like normal or it's like exceeding, it can also lead to the muscle guarding, and it can also lead to deteriorate the situation. It can also it can increase the situation of that pathology which is leading inside that patient or in that person.
I completely agree. And in fact, one thing that's really critical is that all of these aspects are interrelated, and it's almost impossible to distinguish which might be the leading cause. And our task clinically is to work out what are the elements that need to be addressed. And so if someone can't feel their back, one of the strategies to deal with that is to stiffen. If you stop it from moving, you don't have to worry about controlling it. So I completely agree with you. But as a general principle, I don't think we need to identify the leading cause. I think we need to find the package of change and address the component. So we might find with the patient, okay, they've got guarding, excessive recruitment of muscles and guarding. I want to address that. I've also identified that they've got poor perception of their position, their movement, their muscle activation. I also want to address that. So I would be able to identify all of the features, and I would put a program in place to try and address each of those features, regardless of which one might be the initial cause, because I think our strategy clinically has got to be to address all the components anyway. But it equally applies to posture, for example, or movement. For example, someone might present with a posture where they've got excessive recruitment of their back muscles. Is that because they've got poor control of their posture, or is it because the muscles are excessively guarding? So again, there's two features. We don't know which one's driving which, but we would address both with our intervention. But a really good question, because I think it's critical for us to think about the whole system when we put our package of intervention together. Great question. Any other questions? Any other thoughts? What we'll move on to then is to think about pain neurobiology, and primarily thinking about this in terms of how can we understand the mechanisms that are driving a person's pain, and then so how can we identify that clinically, and then why might that help us understand which interventions are going to be most effective. Sorry, I just need to get my mouse to the right screen again. So to start this section, I want you to think, first of all, about why might motor control be effective? So the hypothesis is that the quality of control, so how you control your posture, your alignment, your muscle activation, your movement, that all influences tissue loading. So that if you have too much muscle activation, you've got compressive loading. If you allow the movement too much, you've got increased loading of structures again, because they're able to move further into range. So all of these changes modify loading of tissues. And then the hypothesis is that if you excessively load tissues, that may lead to nociceptor activation. And then if you continue to move in that particular strategy, you may maintain that nociceptor discharge in the long term, and that may be contributing to the continuation of your pain. Now, though that nociceptive input might be sensitized, so you get a bit of amplification of the signaling, but the hypothesis is that neuromuscular control is relevant to pain because it's going to be loading tissues if it's inappropriate. And therefore, it would make sense to implement a strategy where you learn to load the tissues differently. So let's then think about pain. Now, if we look at this picture on the right first, there's some key principles of our understanding of pain neurobiology, which are critical for us to consider when discriminating patients or considering patients in clinical practice. So the first thing I want you to remember is that pain is, of course, an output. So nociception is the input to your nervous system. So it is the input from your tissues telling you that there is something thermal, mechanical, or chemical that is threatening the tissues. So you have put your hand on a hot structure, on a hot surface, or you have tripped over and twisted your ankle. So there is some mechanical, thermal, chemical stimulus that is threatening your body. That information is relayed to your nervous system via your nociceptive neurons, but that's not pain. Pain is then produced by your nervous system in response to that. So remember that pain is the output, what your nervous system generates. Nociception is what comes in. Now, why that's important is because there is not a strict one-to-one relationship between what comes in and the pain experience you have. So if you can have a small amount of nociceptive information, but a very major pain response, or you may have a very large amount of nociceptive information coming in and no pain response, because your pain response depends on other things as well, such as your beliefs and attitudes. So if you are fearful of pain, if you are depressed, if you are stressed, if you have had a period of poor sleep, if you're catastrophized because of previous experience with an injury, in all of those situations, your nervous system might amplify your pain response on the basis of that psychological or experiential cognitive component. So your nervous system can turn up or turn down the pain experience based on those components. It also depends on physiology, or biology. So sensitization can occur where there are changes to neural processes that mean that there is amplification of the signal at different levels of the nerve. So it can be in the tissues, be in the spinal cord, that any region of the stem, the brain. So there can be sensitization where you get some amplification of the signaling or the of that pain response. So why that's important is because it is becoming increasingly recognized that not all pain is the same. And what I've put on the left is currently what the International Association for the Study of Pain considers to be the three main mechanisms of pain. So they talk about nociceptive pain or movement pain, which is pain that is assumed to be predominantly driven by ongoing nociceptive input. So if someone has abnormal loading of their tissues because of the postures they use, the movements they use, the muscle activation strategies they use, they're continuing to load the tissues to drive that nociceptive input. The second group is people who have pain that is maintained by amplification of the neural signaling within the nervous system. And this is called Nociplastic pain or central sensitization. So Nosoplastic is the new term that has been adopted by the International Association for the Study of Pain. And what it implies is that there is abnormal processing within the pain system, and it may be that it's occurring in the absence of any nociceptive input, or it may simply amplify the nociceptive input. And there are certainly many examples of that type of presentation. The most extreme versions would be someone with fibromyalgia, so that kind of generalized pain that's related to sensitivity within the nervous system. And then the third group is neuropathic pain. And neuropathic pain is the very specific category of pain that's attributed to a lesion or dysfunction of peripheral or central nervous system. So sciatica is an example of a peripheral neuropathic condition where there is mechanical or chemical irritation of a nerve, which is driving the pain response. So what you can imagine then is that each of these different pain mechanisms are going to require different treatments because the physiology or the explanation for these conditions is different. So, for example, if someone has nociceptive type pain, then we're going to want to modify tissue loading. We're going to want to reduce the nociceptive input to their nervous system. So that will involve something like changing their posture, their movement, their muscle activation to optimize the load on the tissues to enable the person to relieve the excessive load on those tissues, reduce the nociceptive input. So these are the people who are likely to benefit most from a motor control type intervention. Then there's Nosoplastic pain. So this is the amplification in the nervous system. And you can imagine then that for this group of people, reducing the amplification is going to be critical to consider. And there are many ways we can think about that. So pain education, which is about educating people to understand why they have persisting pain so that they then find it less threatening, they can improve their self-efficacy, they can reduce their catastrophizing. So the pain education really fits in very nicely in trying to reduce the amplification, so managing pain for someone with Nosoplastic presentation. It may also be that you want to apply a cognitive behavioral approach, such as graded exercise. So getting people to gradually do more exercise every day. So not changing the way they move, but changing how much they move. So getting them physically active, getting them back to function despite their pain. So lots of different psychological interventions, educational tools are going to be really relevant for that Nosoplastic type presentation. And then neuropathic pain. In neuropathic pain, there might be some things you can change about movement that are going to modify nerve loading. So changing postures and movement patterns so that they're not putting abnormal loads on their neural tissue, or using neural mobilization or neurodynamic techniques to try and reduce the sensitivity of those nerves. People with neuropathic pain often have some neuroplastic symptoms as well, so they often need some amplification management with psychological or educational interventions as well. So, in a nutshell, I think we need to think about these two extremes. At one end of the spectrum is the people where there is this ongoing threat to the tissues that is continuing to drive nociceptive input, that is continuing to drive their pain experience. For those people, it makes a lot of sense to me that we would use a motor control approach. So address the tissue loading. So modify their posture, their movement, their muscle activation in order to optimize the load on their body in order to resolve their the mechanism that's driving their ongoing pain. But on the other end of the spectrum are these people who have no ongoing threat to the tissues, where there are nosoplastic mechanisms, which are driven by central sensitization and psychology. And in those people, we need to consider modifying their cognitions through education and cognitive behavioral or graded activity approaches. So I think motor control training is going to be very relevant in the situations where if loading on the tissues is causing nociceptive discharge, contributing to their pain experience, then changing their motor control may be the way to optimize loading on the tissues and reduce their symptoms. So there's been lots of discussion in the last few years about when you have a patient with back pain, or with chronic pain, should you treat the body or should you treat the mind? And what I think, of course, is that you need to think about this spectrum, that people where nociceptive input is continuing, a motor control approach is really relevant, and training the body is going to be important. At the other end of the spectrum, where nosoplastic mechanisms are in control, education and behavioral therapy are going to be the most critical aspects. So I think both are important, but our challenge clinically is to identify what might be the underlying mechanisms that are driving the person's pain experience. So what I'd like to spend a few moments on is to just think about, well, how do we do that? How do we actually identify pain mechanisms in clinical practice? And I think we can. It's not going to be 100% accurate. And one of our challenges is that there's going to be overlap. Some people will have both nociceptive and nosoplastic elements to their pain experience. And our challenge is going to be to identify what are the primary factors that might be driving pain for a particular individual. What is the primary thing that you might want to address? Are they right down the nociceptive end or right up the nosoplastic end or somewhere in the middle? So what I'd like to do is to consider, well, what might be the clinical features that allow you to differentiate these different pain types? So let's discuss first nociceptive pain. So we have a pain presentation which is assumed to be predominantly related to activation of these peripheral nociceptive neurons. There's many different names given to it, and I'll make these slides available at the end of the presentation, and with that I'll put some references, and there's a couple of papers that have come out recently that we've published that describe, summarize the whole literature about these pain mechanisms. And there's 1,000 different names that people give to this same phenomenon, but the International Association of Pain has arrived at this term, nociceptive pain. Can I just get you to think for a moment, and maybe if you could put some notes in the chat, just to think about what do you think might be some of the features that would characterize a person with nociceptive type pain? What would they look like? How would their symptoms react or respond? What would be their presentation? And now I can't see the chat, but if you want to put some notes in chat, just some ideas. Can't see anything there, but just have a think.
Should I speak for you?
Yes, that would be great.
Okay. A lot of participants are responding, like local pain, severe spasm, pain related to the
local pain is, so one of the most critical features is pain that is localized to the region. That's a really clear indication of might be nociceptive. Spasm was the next thing you mentioned.
Yes.
So that localized muscle reactions, definitely.
Tenderness.
Localized tenderness as opposed to diffuse tenderness. So if someone has sensory hypersensitivity that is localized to the region of their symptoms, that is indicative of a nociceptive type presentation. Whereas someone who has sensitivity in other parts of the body, that would be indicative of a more Nosoplastic type presentation. Yep.
And another participant said pain related to the movement.
Absolutely. A clear relationship between pain and movement. So a pain response that is consistently associated with increases with a particular movement, decreases with a different movement or posture. Absolutely. That predictable association that is proportional, that is a pain that is provoked, that is within the range of what you would expect. Yep.
Pain in specific movement or range.
Yep, for the same reason. Predictable in range, predictable in response. Yep.
Any physical or potential damage. These are the responses which are given by the participants. Pain proportional to the stress.
Definitely. What
That's
do you think
also
about
no.
what do you think about psychology? Do you think people would do people with nociceptive pain typically present with psychological features as well?
So if you are asking me, then yes, definitely a lot of participants are responding. It can be both. One of the participants said yes.
Yep. And so the general thing is it is normal to respond to a pain experience with psychological features. So it is normal to be anxious about whether you're going to recover. It's normal to be fearful of provocation and those kinds of things. The distinction is that the intensity of those psychological features is generally less in someone with nociceptive type pain than someone with nosoplastic type pain. But it is absolutely reasonable to have a psychological association to nociceptive pain. Okay, so the things that people have come up with are really some of they're really important key aspects. Now, in the systematic review that we've just published, and this came out in there's two, one in the Clinical Journal of Pain and one in Pain. And what those papers do is identify the features that are, it explains the what's considered to be the underlying mechanisms, and it also explains the typical characteristics. So for nociceptive pain, things like generally localized to the area of pain, there may be referral, but the worst pain is in the region of the pain, provoked by movements, activities, postures, pressures, relieved by rest, clear and proportional relationship to aggravating and easing factors. It's usually responsive to anti-inflammatories, to anti-nociceptive agents, to tissue-based treatments. So really exactly what most people have already been suggesting. In terms of imaging, there might be evidence that there is some source of that nociceptive information, but that is not required. So there might be evidence of some tissue injury that is consistent and relevant for the pain experience, but it's not. It is very well accepted that our imaging techniques are not necessarily specific or sensitive to changes. Quantitative sensory testing. So normally you expect that there may be hypersensitivity localized, but not in other regions. And then you also need to consider that to be confident that the person has nociceptive type pain, you might want to exclude the other types of pain. So there are specific questionnaires that help identify neuropathic type pain, and those can help you understand, well, if they don't have that, then that supports your argument that the person has nociceptive pain. So pain provocation tests, so tests where you can typically and consistently turn the pain up and down. And then, of course, as I mentioned, psychological features may be minimal or absent. So what the papers that we've been doing are trying to summarize what all of the literature says. And in the papers, I've also put a few notes about some of the things that people don't necessarily agree on. But hopefully what you're seeing, and I'm going to give you a summary slide at the end that brings together the most critical aspects. But what I think you can see is that we can, by looking at a person's clinical presentation, start to identify what we believe clinically to be the most likely mechanism explaining a person's pain. So let's then think about nosoplastic pain. So amplification of neural signaling within the nervous system that leads to hypersensitivity. So amplification, a bigger pain response than you would expect. So, and again, there's many different terms that people have applied to this particular category of pain, but Nosoplastic pain is the name that the International Association for the Study of Pain has considered to be the term we should adopt. So what, and we've already talked a little bit about some of these things, what do you think are would be the most important signs that would tell you that someone has a nosoplastic presentation? And Mohammed, if you can see the chat,
Sir,
please.
participants are responding. One of the participants said chronic pain, pain not proportional to the movement.
So chronic pain, so people can have pain that persists because of ongoing nociceptive input, but the longer that someone has the pain, the more likely it is that central sensitization will be contributing. So it is, what you've said is true. Definitely a response to movement that is not proportional and not predictable. So it's each time they move, it could be really bad or it could be not. So it doesn't happen in a really consistent way. Any other things?
Hypersensitivity of the pain.
So hypersensitivity in the local region wouldn't help you, but hypersensitivity elsewhere is definitely giving you some idea that it is nosoplastic in presentation.
Pain in more than one region, more tendon
Yep.
points.
Yep. And more than one region and changing, so variable, changing over time, those kinds of things. Yeah.
Disbelief, catastrophizing experience, stress.
Particularly when those aspects are exaggerated. Yep.
Not responding to the posture or position changes.
Absolutely. So an unpredictable, you're not able to find a consistent response to, so you might find that their posture is not ideal. You change it and you don't get a consistent relief. You don't get a change, or it might even make it worse by changing it. So an unpredictable response to things that you would predict should be helpful. Yeah.
Not improving with the pain medication.
Mm-hmm. Yep. And this is a very big dilemma certainly in Australia. We have lots of problems with overuse of pain medications because they don't work. So people increase the doses and they still don't work, and they increase the doses, and it's a big problem. And nosoplastic pain is very poorly managed in the medical with pharmacology.
So far, these
Okay.
are the responses.
Great. So as I said, I'll give you these notes at the end, but there's a bit more detail about some of the underlying mechanisms, but it really is changes occurring throughout in the nervous system anywhere. And it can happen at the cellular level, it can happen at the network level. The characteristics are what I want to focus on at the moment, and that is, so in terms of pain quality, the most important thing is it's nonlinear, that there is a really unpredictable, no clear relationship between pain and the way that people use their body. So it's not predictable in terms of which movements make it worse, which postures or movements make it better. So disproportionate, non-mechanical, unpredictable, not specific to aggravating and easing. It can be all activities that make it worse. it can be provoked at night. Now, nociceptive pain could also be triggered by at night because of sleep postures might be problematic, but this can be a major component of nosoplastic type pain. There can be prior history of major issues that have then sensitized the person to having bigger problems now. So there can be some history that is has led to this. In terms of easing factors, it's very difficult for these people to find postures or movements or changes that are relieving. In terms of location, it's diffuse, widespread, generalized, poorly localized, non-anatomic, many body regions. It can manifest bilaterally, it can move and change. There's also often other symptoms of hypersensitivity. So you might have people who are also very sensitive to sound or light or smell. So there's a questionnaire, the Central Sensitization Inventory, and it includes identification of other sensitivities, which can often be present. They can often have fatigue, memory problems, concentration problems, and they can have sensory abnormalities, not the dermatomal clear regions of anesthesia that you might expect with neuropathic pain, but a more diffuse or unusual presentation. Generally, with imaging, you don't see anything. Quantitative sensory testing identifies sensitivity at multiple remote sites. And often what we do for people with back pain is we use the pressure threshold test at their thumb or at their tibialis anterior. And they have temporal summation. So if you continually give provocative stimuli, their pain often gets worse and worse and worse and worse. So they get facilitation. And then, so in terms of clinical tests, really the key thing is having a really unpredictable response to movements, that the pain that's provoked differs each time and is unpredictable and disproportionate. So, and as I said, there is this Central Sensitization Inventory, which is a questionnaire which gives you some information about generalized sensitivity that can help you identify it. The questionnaires that people use for neuropathic pain, some of the features they look for are also about sensitivity. So sometimes those questionnaires will also identify people with central sensitization. There are some condition-specific questionnaires, like questionnaires for fibromyalgia, and there's several of those. And then you can also use questionnaires to identify pain catastrophizing with the pain catastrophizing scale, fear avoidance belief questionnaire. You can look at pain self-efficacy. So there's lots of different pain questionnaires that can help you understand, well, what is it about their psychological profile that might be particularly problematic. And then there's other specific investigative techniques that you can use. But I think there's a lot there that we can ascertain clinically that will help us pick up when a person has nosoplastic type pain. So then we can also pick up neuropathic pain. So in the past, there's been lots of confusion about differentiating nosoplastic from neuropathic pain. So a lot of the literature has been a little bit unclear about how those two are different. And in fact, there's lots of studies that have looked for sensitivity and called it neuropathic pain. And what the important distinction is that there must be evidence or history of damage or dysfunction to the nervous system, such as evidence of sciatica or evidence of some nerve compression, so carpal tunnel syndrome, or some peripheral nerve entrapment, or some neurological component that explains the presence of pain. Again, lots of different terms are used to describe it. So what kinds of, obviously one thing is there has to be evidence or history of damage or dysfunction of neural tissue. But can you think of other features that would help you identify, yes, this person has neuropathic pain? What kinds of things might they present with? Any ideas? The things that we've
People are
always,
responding.
yep,
Dermatomal patterns,
yep,
radiating, burning
absolutely.
pain.
Yep. Burning, electric shock like, sharp ribbons of pain, all those things that describe neural irritation and dermatomal anatomical distribution. Yep.
Could be localized, referral pain, respond to movement and position.
Yes. So again, this type of pain will be typically responsive to postures and movements that provoke the compromise on the nerve, but the pain that is experienced is different. It will be in this dermatomal, electric shock, sharp. Yeah.
Sharp pain, defined relieving factors.
Yep. And relieving factors that you would expect related to the neural, the neural presentation the person has. So if it's sciatica, tasks that close down the intervertebral foramen might be problematic, or tasks that cause the disc to bulge posteriorly might be problematic. So there's clear idea about what the movements that should relieve should be. Reduced reflexes, areas of numbness, all of those things are going to be relevant. Okay, so there can be different types of neuropathic pain. So primarily what we're thinking about is peripheral. So peripheral nerve entrapment, sciatica, carpal tunnel syndrome. But neuropathic pain can also be central. So people with multiple sclerosis, people with Parkinson's disease, people with stroke, those dysfunctions can impact and give the person a pain phenomenon that is related to damage to the nervous system. So that's also called neuropathic pain, and that can be, but that's specific to those populations. Sympathetic pain is another example of a neuropathic type pain, but it's obviously got a very different presentation in that there are signs and symptoms of autonomic nervous system dysfunction, such as the mottled skin, the cold skin, dry skin, and edema, all of those changes that you relate to the autonomic nervous system specifically. And as I mentioned before, it's very common for people to have neuropathic pain with central sensitization or nosoplastic symptoms. So in terms of the characteristics, it's all of those things we expect from neuropathic pain. So burning, electric shock, shooting sharp, these paroxysmal bursts of pain. They can be stimulus independent, but they're often stimulus dependent. In other words, you evoke them because you move or adopt a posture that provokes the nerve compromise. Generally associated with sensory deficits, so numbness, loss of sensation, paresthesia, dysesthesia. There can be motor changes such as weakness, reduced reflexes, and these autonomic symptoms. The pain location, as we talked about, dermatomal. Aggravating and easing factors relate to the particular neural condition, as we've talked about quite a lot. So history is really important. Is there a history that is consistent with a nerve involvement? Is there some diagnostic testing that's been done, such as nerve conduction studies, electromyography, CT, or X-ray that shows a relevant disc bulge or something that could relate to sciatica? There's somatosensory testing and neurological examination to identify those features of nerve compromise. Quantitative sensory testing, these people can be hyposensitive because they've got compromised nerve conduction. And then there's a whole series of questionnaires: Pain Detect, the LANS, the DN4, NPQ, ID Pain. All of these questionnaires, they can differentiate neuropathic from nociceptive, but many people with nosoplastic pain also score badly because many of the features are about severe or substantial pain. So these questionnaires can be helpful, but you still need to rely on other signs, other symptoms. There are some other clever techniques that people are using, like nerve fiber density testing. So you take a biopsy of skin and as I said again, that in the paper we described some of these less common or areas of dispute. So what I'm going to show you finally, this really summarizes the key things that I think we need to take on board. That is, think about the pain features. Is it predictable? Does it increase or decrease with posture and movement? Is it proportional and localized? Or is it unpredictable, inconsistent, disproportionate, broad areas, multiple areas, changing areas? Is it electric, dermatomal, pins and needles numbness? QST, is it locally sensitive but normal at a distance? Or is it, are they sensitive to pressure and temperature in distant regions? For questionnaires, generally mild symptoms of psychological features for the nociceptive, lots of features of psychological dysfunction that may be specific for the nosoplastic group, and then the questionnaires that are specific for neuropathic pain. For history, there might be a relevant injury that could be the cause of their nociceptive pain, history of nerve damage, or a complete mismatch. So I think there are some things that we can really carefully use clinically to make this judgment. So why is it important? Because I think it helps us understand how we're going to prioritize the design of an intervention for a patient. So if we understand from our evaluation of the patient that the person is likely to have a major contribution from nociceptive pain, then I'm going to spend a lot of my assessment time focused on evaluating the way they use their body, evaluating their posture, their movement, their muscle activation, to identify, are there features of the way they use their body that are driving their symptoms? And that's going to take up the majority of my assessment time and my treatment time. I will also want to understand a little about their cognition behaviors about pain, but it's a less feature. And then my physiotherapy intervention is going to be tailoring a motor control approach to address the features of tissue loading that are relevant for that person. So it might be that I want to use some training exercises to teach the person to use a particular muscle less and another muscle more, or to change their posture and alignment in a certain way, or to change a particular feature of their movement pattern. I may need to include some reassurance, some pain education, some mild psychologically informed intervention, but that's probably not going to be a major component. If I decide that they have nosoplastic pain, I don't really want to spend all of my time evaluating fine detail of the way they move, because it's not going to be the main thing that will change their pain presentation. So for that person, I will do a more detailed assessment of their pain cognitions, of the psychological features. Are they catastrophizing? Do they have low pain self-efficacy? Do they have these general signs of central sensitization? I will also think about their physical activity, but more about the tolerance rather than how it is that they move. And my intervention will primarily be focused on tailoring my intervention to target the psychological features. And then with neuropathic pain, I will do a neurodynamic assessment. I will look at posture and movement and see if it's relevant, but I'll also evaluate some of the features related to possibly their sensitization as well. And I'll target my intervention towards neurodynamic techniques, posture and movement techniques that modify their nerve loading, but then also tailoring an intervention to address psychology. So what I hope I'm presenting here is an idea of how we might optimize our use of time so that we can focus our attention to the treatment, which is probably going to be most effective for the person. And to a large extent, I think that's going to be based on the pain presentation that they present with. So a couple of years ago, I published a paper describing how I think this picture can fit together in terms of designing and optimizing our selection of treatment for a patient. So, does anyone have any questions I'd like to ask about that aspect in terms of trying to refine our decision making about who we should treat with a motor control intervention. I can see a hand up.
Hi, Paul.
Hi.
I'm Imran Amjad here.
Hi.
Thank you for your presentation. It was nice to hear you, because mostly we only read your articles. Not, I have never experienced to listen you personally.
Well, I wish I was there to meet with you personally, but tragically that's not the case.
Yeah. But right now I'm in New Zealand.
Oh, okay.
Okay. Paul, you were discussing in your motor control concept that there are different patterns that could disturb the motor controls. As a generalized, we can maybe we can summarize them that there are some tight controls and that there are some loose controls. And when you are talking here in pain pain mechanisms, you said there whenever there is increased loading, it will cause increased nociceptive receptors. And if I can, if I'm thinking that if the motor control is tight control type of things, then it is mostly chances that it will increase the loading and increase the nociceptive receptors. But on the other side, if there is something like loose control where the hyper flexible, where the flexibility is quite high, in that case, I can understand that the loading is not high. Maybe on one aspect of that thing, there is loading high, but on another side, there is less loading. What do you think?
I think it's different loading. So let's think for example, the hypermobility is a really a good example. And so one thing to think about is that compressive load is one aspect of loading. But if you think about a joint moving, you might have really loose control but it may not be coordinated. So you might have, like when you move through a range of motion, you really want smooth control of the translations and rotations as you go through that movement. But if you've got loose control, so if you've got a nervous system that is not tightly coordinating the movement, you might actually get translations and rotations that are uncontrolled, and that could load tissue. So you might, for example, there is work that looks at people with spondylolisthesis using fluoroscopy, and what they've shown is that there's a dysfunction of the way that you coordinate rotation and translation, so that you might translate further than you normally would, than is healthy for your tissues, than rotation. And that's going to put extra tensile loading on tissues. So there can be extra loading from poor control, but it's more going to be that tension loading rather than the compressive loading. So I think at both extremes, it's going to be a problem. And the either tension or compression of tissue is potentially going to be a stimulus for the nociceptive input. Does that make sense?
Yeah. Thank you. Paul, there is another question. In psychological sensitization pain, you said that it's related to the threshold of nociceptors.
It's related to the
threshold
not the threshold of the nociception, but to how that nociceptive information is then amplified within the nervous system. So generally it's not the periphery that's sensitized, but you can have inputs at the spinal cord that amplify so the nociceptive neuron provides the information to the spinal cord, and at the spinal cord that can be exaggerated or amplified by the synapses at the spinal cord, or it can be higher up. So it's not actually the nociception that's got the difference in threshold. It's what you then do with that information once it's in the nervous system. So it can be
from this one. From this one, you can confirm I'm right or not, that maybe we can hypothesize, or maybe already there is an answer, that in nociceptive pains, mostly these are the acutes. For example, there is a person who have a first time episode of back pain. It is a maximum chance that he or she have a nociceptive type of pain. But the neuroplastic or centralization is a sort of a chronic pain that if a patient has a lot of episodes, then there is a chance that she will be converted to a sensitization things.
Okay, so I think that's some people. So I absolutely agree that pain always begins with some mechanical thing. So there is nociceptive input. So people get pain because they're stressed. That people don't get their first pain because they're stressed. There will be mechanical insult that causes that initial pain response. So in an acute situation, that is nociceptive pain is the main driver. As you've said, over time, it is more likely that you will have a nosoplastic presentation, but it's not the only way pain can be maintained. And so I think many people, like when we look at trajectories of pain, there's different pathways that people go through in the future. There are people whose pain never really recovers. It stays high, and it varies a bit, but it is elevated. And I think those people are definitely sensitization, probably a driver of symptomatology. The majority of people have fluctuating pain, so they have flares of pain, so they have times that they're better, sometimes that they're worse, and a lot of those people, I think there is an ongoing nociceptive component often. It can be exaggerated because of sensitivity, but I think it's people who've repeated episodic back pain, often that is associated with some aspect of nociceptive pain. And it's our job as clinicians to work out for that patient, is it primarily nociceptive or is it primarily nosoplastic? So I think there are, as time goes on, it's more likely that nosoplastic mechanisms will contribute, but I don't think time is the only determinant. And some of our other work, we're very interested in the trajectory of pain and looking at how people recover and these patterns of recovery. And we're doing a lot of work at the moment looking at the factors that predict someone having a flare of pain. And there are certainly some people who are sensitized, and there are other people who are not, where it is. And so the contribution of nosoplastic and nociceptive still needs to be differentiated. Does that make sense?
Okay, that's good. Yeah, that's good. One question with the same question is that, is there any factor or is there any relationship of age for conversion of nociceptive pain or sensitization pain? I can say that, is there any difference that different age groups have different type of prevalence of these things?
That's a really good question. And I'm trying to think of evidence. I don't know. Okay, there are clear things that make a difference, and for example, we know that it's more common for nosoplastic mechanisms to explain pain for women than men, and it's just a feature of some differences in the way that the nervous system operates, and there are different neurotransmitter responses in men and women. But what do you think? Do you think there'd be a difference with age?
Yeah. Actually, Paul, I was thinking before that we will share something with you through email. Fortunately, I have opportunity right now. Actually, I have a hypothesis type of thing that this factor could affect these type of things, and we are trying to formulate a project around this type of hypothesis. And because I think it's definitely, it's my maybe I'm a little bit random, that I was thinking that in young age, the most of the time, and the people have different type of experience, but with the age, the previous experience affect their future things. For example, if someone is in middle age, his response of pain will depend on his previous responses. But a person who is in young age, maybe I'm not accurate, but maybe he has less experience for different type of pains. So as you said, the pain have always have us, you can say, a mechanical source. So in young age, maybe someone have a mechanical source, but he or she didn't have an experience for that one. That pain could be mostly maybe related with, not related, but that pain could be categorized as a nociceptive. But in old age, when someone have a pain, he could relate it with previous experience, and that could be easily converted into sensitization type of things. It's again, these are my thoughts, not exactly.
Yeah.
I didn't find anything.
And that might be the case. But it might also be opposite in that an older individual might have had, because they've had so much experience of no pain, it may be harder to flip them into a sensitized state. I'm not sure. But although having said that, there's lots of other things that happen with age, like systemic inflammatory changes that can increase sensitivity. So there's lots of possible mechanisms that could be at play. But great, send me an email. Let's chat about this. I think that's
sure. And sorry, last question. Yeah. In sensitization, as you know, as you said, emotions are related with pain a lot, and in pathways, in pain pathways, we know that there is a strong connection with the limbic system or emotional centers. So is there any literature available that they differentiate these things from these centers, that there is any evidence that they prove that different type of pains influence different limbic systems? Different central parts in limbic system.
The work of Apkarian, he's done lots of imaging studies and trying to interpret the involvement of the relative involvement of different brain regions in different pain type presentations. So I definitely recommend that you read some of his things. One of the things that's important though is that pain, the interpretation of pain in your nervous system is a network-wide thing. So there is in which Ron Malzak called your neuromatrix. So this whole interaction and interconnection between different brain regions. But the limbic system is definitely involved, and there are certainly some specific profiles that seem to be associated with particular pain areas. And this is actually an area that we're currently investigating in a little bit of detail to try and work out whether there's some neural signatures of different pain presentations. Great question. Yeah, cool.
That's good. Sorry, once again, which group is working on this one?
Apkarian from Northwestern. Apkarian. Apkarian.
Thanks, Paul. Thanks.
No worries. And I see another question.
No, I have no questions. Thank you.
There's a question from another person.
Yes, thank you, Paul. It's a really wonderful presentation, and I happen to have met you in 2001 in University of Queensland when I was doing my postgrad studies. Back then, Nancy Lochai, Lochai was my supervisor in neurology. So it's I'm really happy and glad to see you after such a long time. My question is regarding the nociplastic pain. We know that physical activity has effect on stress and mental health, as well as musculoskeletal and neurological functions as well. So in nociplastic pain, would you does it make any difference to to do any exercise or any physical activity or any motor control specific activity that would have a specific impact on nociplastic pain, or we can choose anything and then proceed with that. Thank you.
So the current evidence, and I'll actually show you some evidence at the end. If someone has nociplastic pain, our goal is to de-amplify, and exposure to healthy movement and the reinforcement of return to healthy function is one way to do that. And so graded activity, so where physical activity is the tool that you use to get a person to worry less about their pain and focus more on return to functional goals. So in a graded activity approach, what you're doing is identifying, you're working through goals with the person, you're identifying so what they would like to do, you talk to them about pacing, you get them to very clearly understand that hurt does not equal harm, that moving, it might hurt a bit more, but that doesn't mean they're harming themselves. And your focus is on every day doing a little bit more. So it's not so much about caring how people move, but encouraging them to move. And they clearly need to have the strength and endurance and the cardiovascular capacity to do that. So exercise is actually probably the most important treatment for that particular group. And we've done a couple of clinical trials, and I will mention a little bit of the data right at the end. And I think it very nicely shows that when you target those features, when you identify nociplastic mechanisms, you target those features, they're the people who are going to benefit most from that type of intervention. If you've got someone with nociceptive pain and you do the same thing, you won't do as well as if you had changed the way they move. So I think there is some good evidence that exercise is a tool to address those people. Yeah.
Thank you very much. Thank you, Paul.
Great. Okay. We have been going for 111 minutes and 20 seconds. I think we might just need a 10-minute break for to freshen up. And then, so maybe if we start again in 10 minutes time, and what I'd like to do is then have a very practical session talking about how we are going to assess and then train, plan a program of exercise to target someone's control. So maybe if we have minutes, so coming back on the hour. Does that sound fair?
Yes, sure. Thank you.
Yes,
Great.
sir.
Okay. We'll see you in 10 minutes then.
Okay, sir. The meeting will remain on for 10 minutes. You can take a break and we will resume after 10 minutes.
Great. Okay, we have hit the
Welcome back,
hour,
sir.
so let's start again. So what we're going to talk about now is to think about how we can apply this into practice, and I really want this to be quite practical. So what I've done is to put together some slides that show some of the techniques, some of the basically with the goal of giving you a taste of the way that we actually go about applying motor control training into a whole package. And as I said before, the key thing that I want to do is to have a bit of discussion about how we might go through the process from day one through to when we might discharge someone at the end with training at a functional level. So I first want to, I'll talk a little bit about what motor control training is in terms of a definition, and then I'll go through this program. And again, it's quite practical. It's really about what are the tests that we might do, and how do we go through the decision-making process. So the key, as will be very clear from what I've said in the first part, is that the motor control presentation or motor control program that you use differs for everybody, because what we're trying to address with our intervention is the specific features of motor control that are abnormally loading the tissues for that person. It might be that one person might have one particular muscle activation strategy or alignment issue. Someone else will have a very different presentation and will need a different approach. So it really does need to be tailored. So clearly what that means is our assessment needs to be precise. We need to be able to carefully identify the features that are relevant for each individual person. So what is motor control training? The first thing is, as I've highlighted, we aim to restore optimal control of the spine and pelvis. So the purpose of that is to change muscle activation, posture, movement, and sensation as is relevant for the person to optimize the load on the structures of the spine and pelvis. So our goal is to try to remove the sources of nociceptive input that come from abnormal loading. So again, it makes sense then that this is going to be most relevant for those individuals who have a nociceptive type presentation. It's matched to the individual specific changes. So we need to identify what is it about the way that person moves or uses their body that is driving their symptoms, so that we know where we want to target our intervention. It needs to be matched to the functional demands. So we might have a person who needs to sit all day. So we need to ensure that we're optimizing the way that that person uses their body in a seated posture, how they move, how they adapt, how they sustain postures over time. But another person might have their symptoms when they're doing some physical activity, some sporting activity like swinging a golf club or swinging a cricket bat or bowling in cricket. So there might be some very specific features of their movement in that function that is particularly relevant for their provocation. And that's what we want to end up getting to in our functional re-education. And then we also need to consider, are there other aspects like psychological foci that need to be addressed? So this slide kind of summarizes how we might go about that, the sequence of our intervention. So in this box on the left is really the process that everyone needs to go through from day one to discharge. The components I've got on the right in red are features that might be relevant for a specific individual, but not necessarily everybody. So they're things that might need to be added in order to achieve the best outcome. So in this box on the left, there's really three phases. The first phase is correct the motor control faults, or identify the features of posture, movement, and muscle activation through assessment that we believe are relevant for the person's pain provocation, to then, in our first component of intervention, change that. So let's say someone has their pain is provoked because they have a poor ability to control their lumbar lordosis in sitting postures and when they perform trunk flexion tasks, for example. Then our focus of our intervention in the first place is going to be teaching that person how to control that. It might be about learning, getting the sensory information they need to learn to feel that lumbar lordosis. It might be that we need to optimize the control of the multifidus, which is the muscle which is really important for control of lordosis. It might be that we need to teach them how to maintain that alignment while they do a particular movement. So it's really about correcting the features that you find are relevant for the person at the, that provoke their symptoms. So first phase, identify the problems and teach them the skills to change that. Then what we want to do is to integrate those skills into function. And what we're going to do is to make the exercise, so correct the faults, but then give them challenges that cause them to consolidate those new patterns and to challenge those new patterns. So for example, one of our paths of progression is going to be through static training. So the person who has poor control of their lumbar lordosis, they need to be able to correct the lordosis and then control that as we apply load. So this is where in that particular strategy, you might be using some leg loading exercises where they control their lumbar spine while they add load through their legs, or they may be doing a Pilates program where they're adding resistance through the limbs and controlling their lumbar lordosis or something like that. We're also going to want them to control that in a dynamic sense. So we want them to be able to control their overall alignment of their spine, potentially while they rotate in another plane, or teaching them to be able to control alignment while they move, control muscle activation while they move. So they're challenging themselves statically and dynamically to be able to consolidate those improved features of motor control. And then finally, getting into their function, whether that's a sport-specific activity or whether it's a specific postural task that they need to sustain for long periods, but really progressing them into practicing their function with their new movement control strategy. And then on the right, you can see that we have things like breathing issues. So you might find that that the patient has a poor ability to control their breathing pattern, and that's or they may have continence and other issues that mean that you need to implement a pelvic floor training program to improve their pelvic floor control so that they can generate the pressures and fascial tension that's necessary. You may need to implement a program related to addressing catastrophizing or fears or pain education to help modify their cognitions about pain. If someone's fearful of moving, it's going to change the way they control their movement. So we really need to think about the interaction between psychology and movement. And for some people, that will be a goal. Adjacent regions. So some people will have poor control of their hip or their thoracic spine or the neck or poor foot control that influences the back. So if someone's got pronated flat feet, it causes internal rotation of the femur, which causes anterior tilt of the pelvis and then potentially an excessive extension. So there may be adjacent regions that need to be addressed to enable them to more optimally control their spine. For some people, really sensation is the key, in that if they learnt to perceive their movements and positions, they would be better able to control them. So for some people, sensory training and really getting the person to attend to and consciously train their perception of position and movement might be the answer. For some people, it's about balance. So they may have particular deficits in their ability to control balance, and obviously that's going to compromise their spine control, and we need to implement some extra training of that, like training with balance boards, Swiss balls, unstable surfaces that are going to challenge their balance demand. They're going to need to have sufficient strength and endurance of muscle, and many people with back pain have structural changes in the paraspinal muscle. So their multifidus muscle is atrophied, there's fatty infiltration, and we need to try to address that with specific training. So it's not just about telling people how to turn the muscles on. We actually do need to progress them into load, and some people do need a part of their program that's really about strengthening and endurance training. And then obviously many people with back pain are deconditioned. They're just not very physically active, and it may be essential for us to add in some physical endurance training just so that they can have a better cardiovascular fitness, a better tolerance of movement. So everyone goes through this path on the right of change the control and then challenge it into function. But then individual people might need these extra pieces slotted in if you find that they're relevant for the person's presentation. So what I'd like to do then is to spend some time thinking about, well, how do we actually go about making this assessment and then planning the specific strategy of training. So it really is about clinical reasoning, and the approach I'm talking about really is good clinical reasoning. It's about trying to challenge the body and identify the features that are relevant to address with training. And so we're going to evaluate someone's posture, we're going to evaluate their movement and their muscle activation, and we're also going to make some interpretation about sensory function while we do that. It is a little, artificial to evaluate these things separately because they are all interrelated. But I'm going to talk about them separately because I want you to think about, well, how do we consider the aspects of posture and movement and muscle activation? So we're up in this top box. There's this box of identifying for the individual what is relevant about the way they use their body. And I'm going to start with posture because I think posture and posture or alignment is a really, it's got there's some clear ideas about how this explains the paradigm of what we're going to assess. So our principle is to think about, well, what is ideal posture? And then how does the posture of the person in front of you differ from that? Now, my first comment is going to be that there is no one ideal, but I think we need to approach our assessment with assuming first, this is what's ideal, and then I'm going to test whether it's ideal for the person in front of me. So I'll look at the person relative to the ideal. I'll correct the posture to make it fit the ideal. And then I'll do some subtle adjustment to actually match their ideal. So I'll start with a very general idea about what I think is perfect. I'll modify it, adapt it to that particular person. For example, I might think that a particular degree of lumbar lordosis is ideal, but for them, it's actually provocative, or for them, it requires a lot of effort to get there, which means it's clearly not going to be sustainable. So I'll adjust my goal to match the person. So our goal is identify features that we think might be relevant because they don't match the ideal. We'll correct them. And if correction reduces their discomfort or pain, and it's something that doesn't require excessive muscle activation to achieve, then I'll think, okay, I've probably found a position that is more ideal for them that might be relevant to target with training. So this is what we think of as the starting point of ideal, and that is what we call the neutral spine. So it's a position where there are several things to consider. The first is that there is orientation relative to gravity. So your C7 is over your sacrum. So if your C7 is in front of that, it means that you've got a moment causing you to flex, which means you're going to need to use extensor muscles to keep you upright. If your center of mass is back, you're going to need to have the flexor muscles. So if you've got this optimal healthy loading position of the spine, you've got to have orientation relative to gravity. And surgeons call that sagittal balance because they recognize that if they do a spinal fusion, and they don't achieve, and that stops the person from getting into this position of alignment. So if they fuse the joints in the wrong position, the outcomes are really bad. So they recognize that alignment is an important thing. So the first thing is orientation relative to gravity. The second thing is then the curvatures within that posture. And it's a pelvis which is slightly anteriorly tilted, a lumbar lordosis, a smooth transition to a thoracolumbar in the thoracolumbar region, to a thoracic lordosis that is gentle, and then a thoracic kyphosis that's gentle, and then a cervical lordosis, again with a smooth transition around the cervicothoracic junction. So smooth curves, no exaggeration. So often what we'll find is that people will be extended in the thoracolumbar junction, or they'll have posterior tilt and flexion of the lumbar spine. So changes from this ideal that put extra load on tissues. In the frontal plane, obviously there's some symmetry. So good balance between left and right. So the benefits of this posture are that it's mid-range, which means that there's no particular structure which is on stretch, which means that there's no structure that's got creep over time. It's a position where there is minimal needed activity to control you against gravity. So muscle activity can be low, so there's less compressive load. It's also a position which encourages the activation of deep muscles. So when you've got a lordosis, you have better activation of multifidus and transversus and the pelvic floor, and a better breathing pattern. So this alignment has many benefits in terms of loading of the spine, but also of optimizing muscle activity. But again, it isn't the ideal for everybody. So for example, someone who's got spinal stenosis, they're going to be provoked by having too much lordosis. So you're going to want to get them a little flatter than the ideal. So there are going to be differences between individuals. The next thing is, I'm not suggesting that this posture needs to be statically maintained forever. I'm suggesting this is a posture that people should commonly use. They should move into and out of and around. So when you're walking, it's good to have this kind of alignment, but be able to rotate in the transverse plane. So you're keeping these curvatures and this orientation relative to gravity, but you're still mobile. You're not just holding it rigidly, you're actually able to move it. So when we evaluate people with back pain, what we'll do is look at their posture and decide, are there features of the way the person is using their alignment that differ from that ideal, so this neutral posture? We'll change it, and then we'll decide, has that made an impact on their comfort, their pain, their activation of muscle? And if changing the posture has positive effects, then we'll consider, well, that's going to be part of our intervention to address that. If it makes no difference, or if it makes it worse, then clearly we've not got the right, we're not finding the feature that needs to be modified. So it might be that they've got posterior tilt and too much flexion. It might be that they're flat. It might be that they've got a sway back where they're hanging backwards and their paraspinals are turned off. Or it might be that they're actively holding themselves in extension. And people, Peter O'Sullivan, Shirley Sarman, the Kendalls, they all had different descriptions of that basically fit into these key kind of postural alignment groups. So the idea then is you look at the person's alignment, you find the features that you think might be relevant, and then you change it to see what impact it has. And our goal is to find postures that reduce the provocation or increase the relief. So that's what we're trying to do, is find postures that relieve the load on their tissues that are optimizing. We might be changing their posture to change muscle activity. So by getting them out of this thoracolumbar extension more to a neutral position may help us reduce that overactivity of the lumbar erector spine, of the long erector spinae. By getting from slump to neutral may allow them to get better activation of the multifidi, better recruitment of the transversus and the pelvic floor. So changing alignment can have the goal of changing their muscle activation. And also, we know that if someone is in an upright position, they have good control of the pelvic floor, and it's easier to have a more natural breathing pattern. If you slump, then it's actually very difficult to contract the pelvic floor. And you can try that for yourselves if you'd like. If you go into a slump position and try and contract pelvic floor and then do it in an upright position, it's much more difficult. But the other thing is it changes your breathing. When you're upright, you can use basal expansion of your chest. But if you're slumped, it all happens in your upper chest. So there's differences in breathing that occur with posture. So we might target posture for lots of different reasons, for changing the provocation of pain, changing muscle activation, changing breathing and continence. So it can be a really important part of treatment. So what this slide shows is that really the two regions where we often find people have the most difficulty is around posterior pelvic tilt and lumbar flexion, and thoracolumbar junction, having excessive extension at thoracolumbar junction. But also don't forget, there's often too much thoracic kyphosis, and there's also asymmetry, so shifts or tilts in the frontal plane as well, or rotation. We've done lots of work looking at the interrelationship between posture and muscle activation, and I've just hinted before that if you have a lumbar lordosis, we have got lots of evidence to show that there's better multifidus activation, better lower transversus activity. That if you're in a thoracolumbar extended position, it really does exaggerate the activation of your long erector spinae, just too much activity, giving you too much compression. And when you slump, all of your extensors pretty much turn off. And if you're in a sway back posture, often the only muscle you're using, because your center of mass is back, is your obliques, your external obliques. So posture really drives muscle activation. So when we assess posture, we'll evaluate posture in different positions, so in sitting and standing, and look at, well, what is the person's natural strategy? Again, what our idea is to identify what features are provocative of their, maybe related to provocation of their symptoms. So we'll look at the sagittal balance. So we'll look at where is their C7 relative to their sacrum? Is it over the top? Is it forwards? Is it backwards? Or at the front, you might use the manubriosternal junction in the front of their pelvis. That should be one over the top of the other as well. We'll look at the curvature. So where do the curves start? Where do they finish? Do they have a lordosis? Do they have a thoracic kyphosis? Is there a smooth transition from the lumbar lordosis to the kyphosis, or is there thoracolumbar extension? We'll look at the cervical and head position. There may be a very specific change. So they may have flexion at a specific lumbar segment, or we'll look at the pelvis. They may have posterior or anterior tilt. And as I mentioned, ideally, there'll be a little bit of anterior tilt. It shouldn't be excessive, and that certainly shouldn't be tilted backwards. We'll look in the frontal plane. So do they have a shift, or do they have an asymmetry of their pelvis? Do they have a scoliosis? Rib cage can also give you some information. So is their inferior angle of the rib cage different on one side compared to the other? We'll look at muscle activity in terms of size of muscle and activity of muscles. So palpating muscles, observing the muscles. Is there clearly some muscles, like is there thoracolumbar erector spinae at the thoracolumbar junction, hypertrophied and active on one side relative to the other? Do they have underactivity, or are their multifidus soft and not contracting? Are they failing to use their lumbar muscles? And you also need to think about the adjacent joints. So in standing, is their leg position modifying their spine? Is their shoulder girdle, is their neck and thorax influencing their lumbar spine as well? So whatever we find, we try to change. And then if we change that, does it have an impact on their pain and on their muscle activity? So through our assessment then, we've thought, well, what are the features that might be driving the tissue loading? We've tried to identify those and then modify them. And then our rehabilitation strategy will be targeted towards the features that we've observed that we believe are relevant for symptom provocation. And we can use a whole range of different strategies. It might simply be about instruction. So trying to make a person aware of the postural feature and making it change. So it might be asking someone to roll forwards on your tailbone so that they can learn to get that feeling of a lumbar lordosis. Or you might get them to breathe into the base of the ribs in order to get them to expand at the thoracolumbar junction so that they're getting out of that strong extension. It might be using imagery. So trying to get a person to imagine a picture of or some description that helps them understand what your intention is. So someone who's got excessive kyphosis can benefit from the image of lengthening their spine. It can be a really nice way to help them encourage to understand what you mean, rather than just say extend your spine, which probably will just make them use their erector spinae really strongly. But lengthen can give us a different picture, which gets you closer to what you actually want. Manual guidance, so putting your hands on and showing them. So putting your hand on their sacrum and getting them to feel the anterior tilt of learning how to get the pelvis into a more normal position. Manual cues, in other words, giving them feedback to enhance their sensory awareness of their posture. So putting their own hand on their xiphoid. So the xiphoid process at the base of the rib cage and the belly button tells you something about thoracolumbar junction. And I think I've got a video of that. I do. So when that distance gets smaller, it's thoracolumbar flexion. When that distance gets larger, it's extension. So you can use that as feedback so that a person knows if they're controlling their thoracolumbar junction. So I'm not suggesting that you want them to practice that as an exercise, but putting their hands on can give them feedback so that, okay, if I do this correction, I'm actually getting out of thoracolumbar extension. I'm controlling the feature that was observed. So using that manual guidance, manual cue can give them extra sensory awareness. This cue, so if they've got their hand on their manubriosternal junction and their pelvis, that this point should be over the top of this point. So one over top of the other. So someone with a sway back would benefit from that feedback so they know, well, where should their thorax be in order that they're not hanging back into extension. So manual cues can enhance sensory awareness so people can learn to feel a different position. Dissociation tasks. So Shirley Salmon has exercises of getting people to move one joint and not the adjacent joint. So for example, someone who moves the lumbar spine too much so they've got too much flexion of the lumbar spine, you can get them to learn to move at the hips instead of the spine. So you're getting them to separate the movement from one joint from the other. Muscle activation, so palpation, so getting people to put their hands on their back extensor muscles to feel, or looking in a mirror, or using EMG biofeedback to be able to reduce that overactivity. Or cues and reminders like taping. So if someone has poor control of their lumbar lordosis, you can put tape on the lumbar spine. So get them into the lordose position, put the tape on a little bit of tension. And then if they go out of that extension position, the tape pulls. So it's just a reminder to get them to try and adopt this more neutral position. So there's a whole range of different techniques. So the objective is try to help the person learn to adopt a different strategy, and so they can practice that to change the loading on their tissues. So the next thing then is to think about muscle. And one thing that I've highlighted several times is the idea that we do care about the whole muscle system. So I want to understand how well is a person able to control their deep muscles? And is there any evidence that they're relying too much on their superficial muscles? So I need to have a test that allows me to assess those two pieces. Now, that's going to be really tough for us to do in clinical practice. So ideally what we would do, we would put fine wire electrodes or EMG electrodes into each of those muscles, and we'd do some functional task and assess, but that's not practical for us to do because it takes too much time, and it's also involves invasive procedures and blah, blah, blah. It's not practical. So we have to come up with some clinical alternative which allows us to make some judgment about the muscle control that can help us make clinical decisions. It may not be perfect because it's a clinical alternative to the method that we know is going to be best, but it's just not practical. So what we've done is develop some tests that allow us to make some judgment of contraction that gives us an ability to determine does a person have underactivity of their deep muscles? Do they have any evidence of overactivity of the superficial muscles? And then we can try to correct that. So what we've got is a test that is a little bit challenging, because what we're going to ask a person to do is do something that is not natural, and that is to isolate the recruitment of their transversus abdominis or their multifidus and use that to judge how well they're using the system. So what we know is that if a person performs this test well, it means they've got good recruitment of deep and superficial muscles in function. If they perform this test poorly, they don't. So what I'm going to show you is a test where we use palpation, and if it's available, ultrasound imaging to look at contraction of the transversus abdominis and the superficial abdominal muscles. And I'm going to go through it in just a little bit of detail. So the idea is it's a specific test of the anterior or posterior muscles where we ask a person to cognitively perform the skill of contraction of transversus abdominis or multifidus independently from the other superficial muscles. So it allows us to see, can they contract the deep muscles? Is there any superficial muscle that is substituting for that? So that tells us, is the activation of deep muscles is that appropriate, or is there excessive recruitment of the superficial muscles? So we're interested in which muscles have they used, which sequence the muscles have turned on, and what's the quality. So I'm going to show you an ultrasound image so you can understand what it is that we're trying to achieve. So with ultrasound, and I don't think ultrasound is essential for the assessment, but I think ultrasound allows us is another clinical tool. So if you have it available, great. If you don't have it, we need to rely on what we can palpate and what we can observe. But ultrasound is an extra tool. What I'm showing you here is the abdominal wall. The transducer is on the lateral aspect of the abdominal wall, just here. And we're looking at the 3 layers of abdominal muscle like the rings of a tree trunk. On the left, this top image is showing you a picture at rest. There is external oblique, internal oblique, and transversus. Now, if a person contracts the transversus, the muscle should shorten. So the actin and myosin should cross over each other, the muscle should shorten. And as it gets shorter, it should get thicker. So transversus, you can see here, is shorter and thicker. This person has been able to recruit their transversus without excessively recruiting their obliques. The one below, what you can see is there's now a lot of thickening of internal oblique as well. So this person has recruited both their transversus and their internal oblique, and that's telling us that their internal oblique may potentially be overactive. So here is a video, which it can't show you. That's a shame. I'll go back to that other slide because it shows you the same thing, and that video did work. So if you look here, what you can see is that this person's able to shorten their transversus. So this is good control. This is someone who can recruit their transversus. It's showing us that they've got a good strategy. So what we're interested in is asking a person to do that contraction And then we're going to palpate and observe the contraction. And what we expect is that when we put our fingers on in this location, so we'll place our fingers just down and in from the anterior superior iliac spine. In that location, the only two muscles you have are internal oblique and transversus. So if transversus contracts, it'll pull on the fascia and you'll feel tightening of this fascia. If internal oblique contracts, you'll feel the muscle bulge under your fingers. So you can feel a difference in the contraction. So what we expect is to feel that deep, gentle tension. There might be activation of multifidus, but there should be very little activation of the obliques. It should be symmetrical. It should be smooth and sustained. They should be able to breathe, and they should be able to repeat it. So what kind of instructions do you give? You might ask the person to slowly and gently draw in their lower tummy, or slowly pull your abdomen away from the flatten your belly below your belly button, or slowly pull your belly away from the elastic of your pants. Or if you put your fingers on your anterior superior iliac spines, ask them to pull those two fingers together. So the idea is slow, gentle contraction of the lower abdominal wall. So the idea is it can be done in any body position, but often getting the person to lie in side lying or supine can make it easier. And the objective is to feel for that slow, gentle tension that is symmetrical, that is sustained, and is smooth. So if you are looking with your eyes, what you would see is slow, gentle movement of the lower abdominal wall. You would see tension, you would feel tension with your fingers, that tensing of the fascia. And if you had ultrasound, you would see that sliding of the deep layer of muscle. You really want to think about what's happening with the superficial muscles. And if you see movements of the pelvis, transversus doesn't do that. That has to be one of the obliques. So you really want to think about, well, which muscles are causing that posterior tilt? Is it the rectus? Is it the external oblique? You can palpate the other muscles and you can feel, is there any obvious recruitment of the other muscles, the external oblique in the lateral abdominal wall, rectus abdominis in the midline, internal oblique, you can feel it bulging in that lower placement for palpation. Ultrasound imaging, as I said, you can really clearly see the recruitment of the internal oblique if it's acting. And if you've got surface EMG, you could also put that on the external oblique. So then for rehabilitation, if you found that the person has poor recruitment of transversus or they have excessive recruitment of the obliques, you're going to think about, well, how might you change that? It might be about changing their whole body posture to find a position that allows them to get better recruitment. You might change their alignment because in a more neutral position, you get better activation. You might need to use instructions or breathing techniques or feedback, or you might need to use manual therapy techniques to reduce the overactivity of the superficial muscles. So their obliques might be really active and you need to do some connective tissue techniques. You might need to use imagery or taping to help reduce activation. And then for transversus, you might want to, again, getting them in neutral will help them get a transversus, help them shut off their obliques, help them turn on their transversus. Using instructions, so those instructions I mentioned before, using the pelvic floor can be a really great way to turn on the transversus because these deep muscles tend to work together. Using manual facilitation by palpating into the transversus, using imagery, using feedback with teaching the person to feel their own muscle with their own fingers, using some taping techniques. So lots of ways that you might go about trying to improve the recruitment of transversus. For the multifidus, our goal is to try to get very gentle, specific activation of the deeper portion of the muscle without just contracting all of the paraspinal muscles. And the assessment that we'll use is the same, and that is about trying to get the person to very gently activate the multifidus. And again, here's some, we often do this in a prone position or in side lying, placing your fingers on the multifidus and asking the person to slowly and gently bulge into your fingers, or imagine you're tensing a cable from the front to the back of the pelvis can give the person the image. Or one thing that can be useful is getting the person to lie on their back. You're palpating the multifidus underneath and asking them to slide the vertebra up to the sky. That can be it's an image that can help. So try that on yourselves and see if it works for you. It doesn't work for everybody, but it can work. Getting people to think about tilting, but not really tilting. So when you tilt, it activates the paraspinal muscles. But if you get the person to do a micro tilt or an imaginary tilt where they're getting the image of that movement without moving, that can help get their multifidus going. And also inside lying, you can ask a person to get them to think about pulling their hip into their hip joint. And that's it's an image that can sometimes help them activate their back as well. So just some cues that might be helpful. Again, our objective is by placing our fingers into the muscle, we're hoping to feel a slow, gentle tensioning of the multifidus. If it contracts with transversus, that's great. But if there's bracing of the other trunk muscles, then it's too much. It should be symmetrical, smooth and sustained. They should breathe and they should be able to repeat it. So again, with our fingers, we should feel the deep tensioning, should be close to the midline and symmetrical. We should see no movement. It should be contracting with transversus, but not the superficial muscles. And with ultrasound, you should see primarily deeper portions of the muscle contracting. And then in terms of rehabilitation, our objectives are very similar. So use techniques to turn down the global muscles, such as posture, instruction, breathing into the base of their rib cage, feedback, EMG feedback. We might use manual therapy techniques to reduce the activity of their long erector spinae, taping across the erector spinae, imagery techniques, those kinds of things. And then for multifidus, it's really about, a lot of it's about posture, because if you're controlling a lordosis, you do have a better ability to activate the multifidus. Trying different instructions, using the pelvic floor or transversus to recruit the multifidus, thumbs into the muscle to give manual feedback, again, imagery, feedback with ultrasound, putting their own fingers on the muscle, taping techniques to help control the lordosis can assist. Some people use electrical stimulation. That will primarily stimulate the superficial fibers, but it can be a way to trigger the brain to know where the muscle is. So a lot of different ideas then about how to change the strategy from deep to superficial muscles. So our objective with muscles is we might be aiming to reduce the overactivity. It might be to encourage the activity of the deeper ones. It might be because we need to change the muscles to change their posture, reduce the overactivity of the long erector spinae to get them out of thoracolumbar extension, improve the multifidus so they don't slump, those kinds of things. Or it might be about changing the muscles to be able to optimize breathing and continence. And then the third piece of this puzzle is movement. And just like we've looked at before, finding the provocative components of movement that increase the pain, find the pieces of the components of movement that reduce the pain. It might be that we're changing movement to optimize muscle and breathing and continence, as I mentioned before. So again, our assessment is about asking people to do movement tasks and looking to see if there are features that we think are abnormal. So this person who has a sway back, they have a poor ability to sustain the alignment of their thorax relative to their pelvis and are excessively loading themselves into extension. So that person needs to learn to control their thorax over their pelvis. This person has excessive flexion at this particular region of the lumbar spine at the end of range. So that person needs to learn to control that inflection. This person in the top right needs to learn to, if you look the next repetition, he's going to use excessive rotation of the pelvis and instead of the hip. So learning to dissociate the hip from the spine could be relevant for that person. This person needs to learn to let go, to be able to use lumbar flexion when they go forwards. So the principle is to be able to identify, by looking at movements, identify the features that we think are relevant and then change them. And there are many different ways of doing movement assessment. And the idea is to pick some specific tasks that are relevant for the person. It may be flexion in standing. It may be taking a step. It may be extension. It may be rolling over in a spine position. So find movements that are relevant and then observe what is it about that movement that is abnormally loaded tissue. You're going to try and correct that and evaluate response. And the key is to observe some specific features, because the most common places that people have problems are controlling around the thoracic function. So they get too much extension thoracic when they move, or too much flexion and posterior to the pelvis, too much the anterior pelvic sway and some sway back, or it may be that they're using their lumbar spine instead of their hip. So they are some of the key features you will observe for try and judge a movement pattern. Then with training, your objective is to modify that. And it's the same things of using instructions, imagery, manual, so showing them, using hands to get feedback, looking at association, so learning to move the hips separately from the spine, cues for their muscle activation, taping strategies. So a whole lot of different ideas. So clearly that's a brief overview, but obviously in today's session, that's all we have time for, but a brief overview of how you might go about identifying for the individual patient what features might be relevant for their recovery. And then you're going to find a strategy that helps them learn to change that so that you can then implement that in their intervention. And again, a critical thing is going to be to decide, do you also need to evaluate these other functions? Do you need to look at their breathing? Do you need to look at their continence function? Do you need to assess their psychology, etc.? In terms of progression, you might do one of the steps for progression are, first of all, to, once they've got this ability to correct the pattern, you want to challenge them. And for example, using static progression is one way to go. So I'm going to show you a video. So this is a person doing a leg loading task, and very clearly, he's got a very poor ability to control around the lumbar spine and pelvis when he does that task. But with training, what we're able to achieve is good control of alignment. So this could be an exercise approach to challenge his ability to control the lordosis under load. And there's lots of different examples of how you might achieve this. So learning to statically control alignment as you add load through a limb, using rhythmic stabilizations from proprioceptive neuromuscular facilitation, using some of these plank exercises to get a person to control the orientation under load over time. And then dynamically, so you might want to add in, well, you need to add in some progressions that load the system with movement. And again, here's some examples where this person is on an unstable surface. So he's on a foam roll, which means that as he moves from side to side, he has to be able to control his alignment during that movement. This person's moving through a range of motion. She's controlling her lumbar lordosis as she translates around as she rotates around the transverse axis. This person, she's on a Swiss ball. So she has to be dynamic, because as soon as you're on an unstable surface, you have to move to maintain balance. And then finally, you get to function. And that means that what you want to do is to integrate their correction of their problems in correction of their specific features in a functional context. So for that particular component, what you want to do is to get the person to, first of all, correct that feature and then perform their function. You're going to assess the function first. So have a look. When they do their golf swing, when they run, when they do whatever it is that they do, you would assume And what you will generally find is that the features that you've observed in these simple tests will be the features that they have poor control over. And then you want to give them strategies to try and correct it in that context. So what I've tried to do, and again, it's obviously been rapid because we've got a short amount of time, but I hope I've given you a taste of what a motor control approach would look like. And clearly, a key feature is that it's individualized to match the individual patient's presentation. What I want to talk about very briefly at the end is just some evidence, and then we'll have a few minutes for some questions at the end. So what I want to do just for 5 minutes is just to give some idea about, well, what is the evidence that this approach is effective? And there is a lot of evidence from a series of trials that shows that we can change structure and function of deep muscles. We can reduce overactivity of superficial muscles. We can improve proprioception and spine posture and movement. So through training, we can achieve all these things. For example, if we measure the atrophy of the multifidus muscles, so the cross-sectional area of multifidus, people with back pain have asymmetry. So on the side of their pain, their multifidus is smaller. With training, we can make it symmetrical within a few weeks after an acute episode. If they don't train, it doesn't recover spontaneously. So we can change structure. I've done studies that show that if we take people with back pain who've got this delayed transversus activation, if we train them, we can shift those responses to be earlier. We've done studies looking at the organization of the brain. So we map out the motor cortex of the brain, and we've shown that if you do walking, nothing really happens. But if you do a motor or learning program, we can actually make the brain change so it now matches people without pain. But there's some really critical things to know. And one is that there are a series of clinical trials that show very large effects of this intervention on people with pain. And these interventions were specifically tailored to the individual with specific groups of people with back pain. And those studies show big effect size. There are also studies where they take everybody and they treat them in a very general way where everyone gets the same treatment. And what they find is a smaller effect size. So there's still an effect, but it's not necessarily larger than other treatments. But all of those studies applied the intervention in a non-specific way. So everyone gets the same exercise, which doesn't make sense to me. So what we've been doing is recently some studies where we're trying to test whether individualization of the training makes it more effective, and does it depend on the pain presentation. So we've done a study several years ago where we randomly allocated people with non-specific low back pain to either have an intervention that was this motor control program of changing motor control, or a behavioral therapy program where that was graded activity. So just forget about how you move, just move more, use pacing, the intervention that I talked about before. And what I say first is that both interventions were effective at reducing pain and increasing function for these people with chronic non-specific back pain. But we also found that for the people who had a nociceptive presentation, they did significantly better with motor control, and those with a nosoplastic presentation did better with graded activity. So I think that tells me that I need to consider the mechanism if I'm going to plan an appropriate strategy for training. So what I've tried to do, so what I think is there's great evidence that the intervention is effective, but I think we're getting closer to understanding for whom it is most effective and how we should apply it to achieve that effect. So in closing, what I'm going to say is that we do need to be specific in our treatments in terms of applying the right treatment to the right patient. And motor control intervention is appropriate for some people, a large proportion of people with back pain, but not everybody. And understanding the pain mechanism will help us understand where we want to target our treatment. Do we want to focus on the biology and change loading, or do we want to focus on the psychology or social factors and reduce the amplification of their pain? So what I've tried to talk about is this idea that spine control does require this balance between movement and stiffness, with a coordination of a complex system of muscles that involves a range of neural mechanisms and the trunk muscles can be coordinated to meet all these different functional goals, but you've got to balance movement and stiffness. That pain and motor control interact in different ways, and we need to understand for whom motor control intervention is going to work. It's going to have a positive impact on the patients where nociceptive mechanisms are at play. So nociceptive presentation can be present in people with persisting symptoms, but not in everybody. And we need to try and work out who those people are using those clinical tools of differentiation. So our treatment needs to be targeted to pain mechanism, but also to the individual patient's presentation. So I'm going to finish there, but I do have we do have a few minutes for some questions if people do have things they'd like to ask. I am going to make a PDF of this presentation available for you. They'll make available to Mohammed, who can put that on the website in whichever way. But also, if you want to keep in touch with the things that we do, that's the my Twitter feed where I release any papers that we publish. And we have a website that we've made for patients so they can understand about management of back pain and motor controls in there, but in the big context of back pain in general. So thank you very much for your attention for this afternoon. Thanks for attending the session. And yeah, there is a few more minutes for questions if people do have things they'd like to ask.
Thank you very much, Dr. Paul. It was a wonderful session. Now the question and answer session is in progress. Any participant who want to ask any question, more than welcome.
I see a hand up. I'm going to.
Hi, Paul.
Hi,
Imran is here.
Yeah, hi.
Okay, I have a question about motor for treatment. Is there any relationship of the repetition of movements for motor control that we can give to, that we can advise to the patient? Is there any relationship to relearn or de-learn the patterns they have in their brain?
Sorry, are you asking how many repetitions do you need to relearn?
Yeah, I'm asking, is there any relationship between these repetition with these patterns or the effectiveness of these treatment or something like that?
What we know is that if we can change these patterns, it is related to changing their symptoms, but it does take time. That does take practice. So people do need to they need to repeat the training over time to learn to change their patterns to make it become part of their repertoire of movement. So we published some papers, Henry Tsao, T-S-A-O, he was the lead author, where we looked at the progressive changes over time, but also the relationship between motor changes and pain changes. So we do have some evidence that it's that they're related. But as with any motor function, it does take practice. It's never going to be instantaneous. There has to be repetition, and it does involve substantial repetition over time, practicing these new movements and putting them in different contexts for them to become to make them transfer into other functions.
Okay, that's good, perfect. And last question, is there any, which tool you recommend to categorize the different type of pain in back pain?
Do you mean in terms of the pain mechanism or in terms of the movement patterns?
In the pain mechanisms.
So, okay. we're currently working on a consensus approach. So there is some work that's been done by, particularly by Jonas from JONIJS from Belgium, and Keith Smart from the UK. They've published papers that describe methods to differentiate. But we're currently doing an international consensus project where we're asking 50 world experts to help us derive the most likely and viable and accurate clinical methods to differentiate. So I would recommend the papers by Keith Smart and Jonas at the moment. But within the next year, hopefully we'll have published the international consensus approach to differentiation.
Okay, perfect.
So,
thanks. Sorry.
Muas Shraim, SHRAIM, he's the author of a series of systematic reviews that has led to this consensus approach. And we've just finished the first phase of that 2 weeks ago.
That's good. Thanks, Paul. Thanks.
No worries. Okay.
Any further questions from the participants are more than welcome. Although we are concluding this session, but Dr. Paul is here and it's a very golden opportunity after this wonderful session.
And I'll be back again on Sunday evening.
Yes, for the keynote speech.
Yes, and there's a panel discussion after that. So if you come up with a question, more than happy to answer them too. Or contact me by email. Yeah.
Sure, sir.
Great.
Paul,
I see your phone.
Yes, I just wanted to say thank you.
You're very welcome. Well, thank you very much, everyone. And thank you, Mohammed, for organizing the session and hosting it for us.
Thank you very much.
Thoroughly enjoyed it.
On behalf of Riphah International University, I am really thankful to all the participants, especially Dr. Paul, for this wonderful session. We are really thankful to you for presenting us today in the workshop. And for now, we would like to conclude today's session. So thank you very much and see you on the keynote speech in the second day of the conference. Okay, sir.
Right.
Thank you very much.
Yeah.
Bye
Bye-bye.
from Pakistan.